Well, hi, everyone. I'm Daniel Williams, senior editor at MGMA and host of the MGMA Podcast Network. We have an MGMA Insights episode today, and we have a new guest to the show, Dr. Jonas Bromberg. He's a Psy.D, and he's a principal at Crossroads Health Consulting. And I had an opportunity to moderate his presentation at our recent Summit event. So many of you may have seen him there. We just hit it off, and I was so interested in what he had to say about behavioral health integration and how that can be applied to medical practices. So we have him on our show today. So Dr. Bromberg, welcome.
Thank you, Daniel. Thank you for having me.
And for our visual listeners, we use both audio and video. I asked you this same question at Summit. You have a beautiful background, and tell us about that. What are we looking at, and what does this space mean to you?
That's a view of the skyline of Boston, Massachusetts, where I reside, and that's looking across the Charles River at the part of the city called Back Bay.
Okay.
And it's a city I've been in for over 35 years and now call home.
Wow, that is beautiful. And we talked about this. MGMA in the last 7 years has had our annual conference twice in Boston. And I told you back in 2018, I was with a group that had rented out a little yacht, little boat, and we just cruised around just kind of where your images are showing. And it was so much fun. And we got everybody that was there got great photos. We went right. It was one of those sunset and mimosas or something like that. Yeah. I don't know exactly what it was, but it was a lot of fun. And what a beautiful city. I love Boston. And dating myself a little bit, back in the 80s, I was just a fanatical follower of Larry Bird. I just loved the Celtics, the Bird Celtics, and I actually got to go there. Not in Boston, but the Celtics played in Atlanta, which was closer to where I lived, and so I drove over there and got to see him when I was still in high school. So it was a lot of fun. So
that's fantastic.
Yeah. So you've been there 35 years. That is fantastic. So tell us a little bit about your background first. You have a Psy.D. Tell us about maybe a little bit of that academic background and where you got involved, where you were really thinking about behavioral health.
Sure. So Psy.D is a type of doctoral degree in psychology. It's actually a doctor of psychology rather than a doctor of philosophy, PhD. Okay. And the Psy.D model of training sort of emerged in the 70s as an alternative to more traditional academic PhD type training. And it was, more of a clinician-focused training people to do, psychotherapy, psychological assessment, hands-on clinical practice. And so that was the type of program I chose. It offered a lot of practical experience while you're doing your academic training. And I trained, here in Boston. That's what brought me to Boston, and trained primarily in academic medical centers. And very early on, had some training experiences with the Department of Behavioral Medicine at Boston Children's Hospital. Did some training at the Dana-Farber Cancer Institute, where I worked with children and families that were dealing with cancer. Worked in a cardiology program. There was a joint program between Children's and Brigham and Women's Hospital. So had a lot of opportunities to, work at that intersection of mental health and medicine, sort of taking care of the emotional life and spiritual life of people that were also being cared for by physicians for some primary medical reason. And that's sort of what got me into behavioral health integration, which I many years later, helped launch a program at Boston Children's Hospital that was integrating mental health clinicians directly into pediatric primary care practices across the statewide network of practices that were affiliated with the hospital.
Okay. So we both have used that term behavioral health integration. Let's define it. What is that? What does it look like in practice, just so all of our listeners know exactly what we're talking about?
That's a great question, Daniel, because it's one of those terms that
It gets thrown around.
Umbrella term, and a lot of different things.
Right.
There are different models of behavioral health integration. There are different levels of it, and to be very specific, it's a way of working. It's something that primary care tends to be the medical place where most of behavioral health integration happens. Although, I was integrated at Dana-Farber. I was integrated on the Boston Adult Congenital Heart Program. So it can happen in specialty medical programs as well as primary care, but probably most of it, is happening in primary care. And it's really a systematic way that the clinical team works with a mental health specialist in the practice.
Okay.
So they're seeing common patients, documenting in the same electronic health record, being able to directly consult with each other in the moment or in a scheduled time, follow up with patients at, whatever intervals. And so it's really an ideal venue for treating any kind of mental health related concern, and including substance use concerns.
Mm-hmm.
Primary care is, one of the main locations where those problems are, detected, come to light. Parents especially turn to their pediatricians first when their children are struggling with behavioral issues, emotional issues. And so it's really an ideal location to get involved in caring for somebody with a mental health or substance use concern really early on. And obviously, if you can get involved and care for somebody, provide treatment, and early on, it's going to be an easier treatment. They're going to benefit from it. You really have an opportunity to get involved early. A lot of physicians, they'll take a wait and see approach.
Mm-hmm.
If it's not, really interfering with a person's life, because they don't know what to do. So, part of what we did in our program was provide a lot of education to physicians to help them not only detect mental health problems with greater accuracy, but also to, be able to ask patients better questions to elicit that information. We taught them how to conduct routine screening around various types of mental health and substance use concerns, so they can really, be that first line. I mean, that's
Mm-hmm.
what primary care is designed to do, be the first line of care. And so why not provide mental health in that same way that we provide physical health? The mind and the body are connected.
They are so connected, and it brings me back to some health issues I had about 30 years ago. I kept having stomach issues, and after the second or third or fourth oscopy that I had, there were the different ones that I had. The doctor finally, after not finding anything there, coming up on the diagnosis there, really saying, well, maybe this is more of a mental health issue. And maybe with this integration, just giving that as an example for you, if it was already integrated and you had a patient like me coming in with stomach problems and tests being done and different question and answer sessions with that patient, what does it look like if you have that integration? Because this went on for, I would say, a couple of years before they finally said, the doctor just pulled me aside and said, hey, we're not finding anything physically in your stomach or in that area there. However, you're still having a lot of pain and a lot of problems with your stomach. So what would that have looked like if we had had that behavioral health integration right off the bat?
It's a good question. It's very likely you could have, spoken to somebody much earlier on and gotten some guidance around, managing the physical symptoms you're having through a behavioral approach or making lifestyle changes. Many medical conditions, can be, helped by lifestyle behavior change, whether it's, exercise or diet or, relaxation or, doing something to help, calm the body, that's connected to the mind.
Right. And that's what they eventually found with me. It was very stress related. I was literally stressing myself out, and just not handling stress, life, whatever, in a very productive way. So it would manifest itself, as you were saying, that mind-body connection, just having incredible stomach pain and other things like that. Yeah.
So it's interesting. What it made me think about, many years ago, I was involved in a project where we created a website to help people with migraine headaches do things to, manage their conditions, self-management, to teach them self-management skills to manage their headaches. And we did some rigorous randomized control research around this, looked at people before we intervened with them and then afterward. And the really interesting finding from that research was, while we weren't able to reduce the reported level of physical pain related to their migraines, a lot of different things, like feeling more in control of it, more confident that they could do things to manage their pain. Those scores went up, incredibly. Even though when we didn't change the level of pain, we made people feel better, feel more confident and capable of managing their pain, which, led them to, also report a greater quality of life. So significant finding, even though we didn't change their physical symptoms, we helped them live better.
That's wonderful. So let's talk about another aspect of behavioral health. And there are some stigmas related around that. Some appear to be going down a bit, particularly what I've noticed anecdotally in reading articles during the pandemic, people feeling more vulnerable in a way, and openly vulnerable, to say, hey, I'm struggling. I'm feeling sad. I'm feeling depressed. I'm feeling anxious about all that fear that was around COVID-19 and issues related around that. Talk about how having a behavioral health integration in a practice can help perhaps reduce or at least address some of those stigmas around behavioral health.
Yeah, no, that's a really important connection that you're making there. And certainly, the idea that we would convey at a very high level was, mental health is health. Again, the mind and the body are connected. And, we would teach doctors to say things like, we're just as concerned about how, your emotional health as we are about your physical health. And we can address all of that, right here. Tremendous amount of stigma, around going for help for mental health concerns, maybe even more about substance use concerns. And, we live in a world that has a lot of different kinds of people in it. Some of them grow up in cultures where you don't talk about this kind of stuff, just naturally. It's not part of what you do, even when, there's recognition you could benefit from that kind of thing. You may not even recognize it, I guess. But making it part of the culture of primary care, really helps, convey that message. Every part of your health is, why you're here, mental health, physical health, all of it. And it just makes, I don't know, I can't cite the percentage, but it's a lot of people that get referred to a mental health specialist that never follow up. And, many people go, and, particularly people that live in rural communities where there's a very identifiable mental health center, they don't want their car to be seen parked in the lot of the health center, right? They don't want people to know. But if you're only going to your doctor, that can be for any kind of reason. And it just lowers the bar, makes it easier. And again, part of the approach that we try to help practices evolve is to say, really, so the patients get the message that, mental health is health, and you can come here for any kind of concern. And that's normal. We want to care for you in that way.
Okay. Let's define one more thing, because we've used the terms behavioral health integration. We've used behavioral health, and then you're also using mental health. Are those the same? Or if they're not, how are they different?
They get used interchangeably. Both of them can be correct. I would say behavioral health is kind of a bigger umbrella term. Mental health might be a large component of behavioral health, but I also would put in under the behavioral health umbrella things like, lifestyle change. People that are seeking to reduce weight or exercise more, change their eating behavior. I would consider those more behavioral health issues related to somebody's behavior rather than mental health. So I would say mental health may be a subset of behavioral health, but they can be used. They are used fairly interchangeably, but it's a good point. I would say behavioral health would also include substance use and addiction sort of under that umbrella. So that's a bigger, broader term, but often is used in place of mental health.
Okay. Thank you for clarifying that. So healthcare is about caring for patients, but there is also a bottom line component to it. So what is in it for providers? If they go, okay, I'm hearing what Dr. Bromberg's saying, maybe I'll consider this, but what is this going to look like when they think about their practice, the model of their practice, and perhaps from the financial side of it? Let's just start with the model of it first, and then we can look into the revenue side of it, the bottom line part.
Yeah. The model that I have worked most of the work that I've done is helping practices implement what's called a primary care behavioral health model, PCBH. And the emphasis here again is really, fulfill the same functions as primary care. This is the first place people are going to turn. We're going to take a shot at, understanding what's going on and trying to intervene, but recognizing like this is primary care. And in the same way, a doctor might begin to intervene if you had a medical problem, but then pass you off to a specialist. We're going to try to do this, here in an easy, simple way, especially if it's something, you told us is really in an early stage. We can probably take care of that in a primary care type model. So it involves having a one or more mental health clinicians, a licensed psychologist or a licensed clinical social worker in the practice and available to see patients as these things come up. Ideally, the mental health practitioners that I think are most ideally suited to work in this type of environment, like their primary care medical counterparts, are generalists. Anything that walks through the door is sort of the ethos of primary care. We try to handle it here, and if we can't, we send you to the appropriate specialty place to have it taken care of. But you want to be able to, that old adage, strike while the iron's hot, knowing that many people don't follow through with a referral to a psychologist or social worker. If you can say, wait a second, I know, you just told me, or I see on this screening, form that you completed that you're struggling with anxiety or depression or something, I have somebody here that can talk to you right now and really help me by, talking to you, in a little bit greater depth to find out a little bit more detail about what's going on and really start to help you today. I mean, you can leave the office today with some guidance on how to manage this. So that's the opportunity we're trying to seize, and these clinicians really, to be available, right there when patients need them. And obviously, once you start getting involved with patients in that way, they may need some follow-up. So the model actually builds in some scheduled follow-up as well. And, it's creating this balance between that real-time availability to, step into the room and, meet the patient right now while they're there, because they might not come back.
Right.
Take the opportunity when you can. And many people need more than that one shot sort of consult. So you have some scheduled time that can also see them for follow-up and help them, in a little bit more longitudinal kind of way.
Okay. So let's go to that part 2 of that question, and that is the bottom line part, the billing part. So what do our listeners need to know as far as the billing, if there are any codes they need to know about how to bill, how to get reimbursed, just so they are compensated for the work that's being done?
The program that I directed for more than a decade. So when we started that program, one of the things that we made available to every practice was some billing consultation. And the person that we had, they used to say, it's different, but not difficult. Many of the standard business practices that you would use to make sure that your revenue cycle is well managed on the medical side is going to be very similar to what you're going to do with this mental health stuff too. Verifying insurance ahead of time, making sure that there's coverage for the things that the services you're going to provide. So, all those things that you routinely and rigorously do to run your medical practice, you're going to do many of those similar things on the behavioral health side. Probably the trickiest thing in behavioral health is sometimes the actual insurance benefit may be carved out. So the bills might be sent to a different entity than the primary medical insurance. Once you understand that and figure that out, it's just different, not difficult. But I think early on, that's often something that billers in a medical practice may not have ever encountered before, but it's not a difficult concept to master. There's really about, in the work that we did, I would say it's much simpler than medical billing. There are probably, 7 to 10 procedure codes that make up like 90% of your billing. So, once you figure out those codes and the modifiers you need to use, and, again, there's a little trial and error maybe, but hopefully not trial and error. Hopefully there's good knowledge out there. Every insurance company, is a little bit different in terms of the modifiers, and, you have to decode what their instructions are, and, to be able to do that regularly. And, so beforehand, we made sure that mental health visits were going to be able to be billable the same day as medical visits in the practice. There was maybe a small number of insurance companies we needed to, make a stipulated sort of change in a contract, but otherwise, because they were different types of services, mental health and medicine, medical services, that largely wasn't a problem, but, it was a concern, it was something people thought about, and again, once bills are submitted, that same sort of just disciplined revenue management stuff, following up, knowing how to, deal with claims that are sent back in an efficient way. And again, it's a learning curve, and it's just different, but not difficult. Almost every single practice that we taught to do this was at least able to break even, if not add to their bottom line a little bit. I don't think anybody's getting rich providing mental health services, but, many programs were able to, derive a level of revenue from that integrated work that not only supported the mental health clinician, but allowed them over time to add other staff resources, coordinator type people that would focus on, that population, build, sort of the administrative staff to support the behavioral health team in the same way that, there's a sort of a legion of people behind every physician on the back end that do things. And, programs that were really successful were able to, generate enough revenue to cover their clinician. And sometimes, those special staffing positions that, supported the behavioral health clinicians in the practice.
Okay. Now, you said that a practice may not get, rich or so by integrating it. However, what are some of the measurements? How do you know if you're succeeding in what you're doing? What should a practice be looking at?
Generating revenue is one way of looking at the value proposition. Well, there was a managing partner in one of the practices I worked with for many years who said, it doesn't matter to me if we break even, because this frees up physician time. I think every one of my doctors can see 1 or 2 more patients a day when they're able to, not get bogged down in one of these mental health things. They can hand off in real time to somebody else that can take over, and then they can go on and not get their schedule backed up and see more patients, be more efficient. Another way of looking at, the value and what can be added. If a physician can be more productive, you don't need the revenue from the mental health person maybe to be as great. Families absolutely love having this kind of access. What it does in terms of creating, loyalty and satisfaction on the patient end is just enormous. I mean, you should, testimonials of patients the families would offer were just, incredible about how helpful it was to have, somebody will be there right away for the family, and certainly when, urgent things come up, to be able to access somebody right away. They really value it. So those are other ways of looking at the value. So remind me again of where you wanted me to go. What was the next question?
So, no, I think you answered that. I was looking at how do you measure it, and it sounds like patient satisfaction and also provider satisfaction by really freeing up those providers for questions that they're going to have to refer anyway. When they start hearing that mental health aspect of the visit coming up, they can move them into that next room and have that professional work with the patient in that capacity. Yeah.
And, it reminds me of a conversation I had with one of the pediatricians who said, the integration of behavioral health and medicine, he thought was the most important thing to happen in pediatrics since the invention of the vaccine.
Wow.
And I said, John, really? There's been a lot of advances in pediatric medicine since the invention of the vaccine. He says, no, this is the most important thing because what it's done to sort of teach me about how to take care of my patients and empower me to do that is remarkable. I'm way more, capable than I was earlier in my career. And, when I thought about it, that's incredible. At the beginning, I was really thrilled about how many kids and families were getting care. The volume of care that we were delivering was enormous. But then I thought, this comment, each one of those doctors we taught, they touch hundreds or thousands of lives. So, to empower these doctors to take care of thousands, hundreds of thousands of patients we care for in our network, that was really something. That was, to empower doctors in this way felt really important. And we had actually done some research about, some sort of pre-intervention and post-intervention with providing educational intervention to physicians, the comfort and confidence they had in addressing mental health concerns that, went nothing but up, Well, just by providing good, solid education and some availability to consultation, just made them feel much more capable, because prior to that, that patients would come into their office and they wouldn't know what to do. They wouldn't, know how to even reliably utilize the system outside the office, to engage patients in care. But the world sort of changed for them.
Yeah. Last question then. I made a note during the summit conference in your presentation there. You said the biggest challenge for practices isn't whether to do it, behavioral health integration, but it's knowing how to do it. You've been covering that, but we've covered a lot of ground here today. So for a practice that's hearing you today, what's maybe a first step or two they should look at doing to bring that integration into the practice?
So when in the work that I do, when I work with a practice, I think the first thing I want to do is, not after I understand what they're doing now, is help them understand what their needs are. Not every practice, given their location, the population they care for, who they are as a care team, what do they need? What are the most common sorts of concerns that they're seeing? And, so we, would often ask practices to do a bit of a time study or, use the data that they have to look at, what the most prominent concerns are. And not only helps you think about how to structure the program you're going to build, but also the types of clinicians you might want to look for when you go to hire. The other thing I think is super important, we always approach this in every time I work with a practice, I approach this in an ecosystem kind of way that this involves a bit of change in, organization and structure in the way certain things happen in an office. And that affects a lot of different people, from the person that greets the patient when they walk through the door to the person that sends out the bill on the back end. It touches a lot of people in between. So we want every member of the staff to know about what we're doing, why we're doing it, to understand the value that it provides to families and how satisfied they are, so that the whole ecosystem in the office can, buy into it. You really want a high level of, sort of buy-in and engagement. Yeah, we're doing this for the right reasons. So that's a really important first step to take too, to, make sure everybody's on board, because because it's going to affect a lot of people, in a very positive way. And that's a story you want to tell. And I always encourage practices that are doing this to, with some frequency, to highlight those success stories, remind everybody, re-engage everybody about why we're doing this. It certainly doesn't make life easier to take this on, right? But for all the right reasons, it makes sense. It empowers physicians, provides higher quality care, generates patient and provider satisfaction. So, it's worth the lift.
Well, Dr. Bromberg, before we sign off, I want to give our listeners an opportunity to connect with you if you have any additional information you would like to share. So provide, if you would like, any kind of contact information or any other benefits they might learn from you about that healthcare, behavioral health integration in their practice.
Yeah, I'd be happy to, field questions, follow up with any of your listeners that would like to, if they want to, sort of learn more. And this is what I do day in, day out at Crossroads Health Consulting is, support practices that want to do this in a variety of ways. So, I'd be happy to, have you put my information in your show notes and have people contact me. I'd be happy to continue the conversation. And, I'm available to help practices, do this kind of work if they want an experienced guide to help them.
All right. Well, Dr. Jonas Bromberg, thank you again for joining us on the MGMA podcast.
Thanks, Daniel. I really appreciate the opportunity, and it's always fun to talk about something I am really passionate about, so thank you.
It is very clear your passion shines through, and thank you for the work you're doing. And everybody, as Dr. Bromberg said, we will put those resources and links in the episode show notes. I'll also provide a link to an article we're going to develop on this conversation here. So until then, thank you all for being MGMA podcast listeners.